share screen. Slideshow. And where were we?
Oh, we were at the agents that inhibit protein synthesis, but I could be wrong.
Well, we didn't start that phase.
Is that where we are?
Yep.
Okay. So the azoles. Everybody good? Recording's going, sharing's going. Everything looks good. Here we go. So we got 4 joining us from Zoom. We have 4, 8, 12, 13, 16 in here. So that gives us 20. Okay. So the azoles, and this is fluconazole, ketoconazole, itroniconazole, are antifungal drugs. So we're going to get to fungals coming up, but these would be, they inhibit the ergostol synthesis. Many are used to treat the systemic fungal infections. So as we move into fungals, we will see where these will play a role. Clotrimazole and miconazole are all used topically because they are not too toxic. They're too toxic to be given systemically. And we have some names that you may have heard of. I don't know if you've heard of miconazole. It sounds familiar. It sounds like we might have heard of that one. Ketoconazole structure. So we're here. Let's find it in here for us. Macrolide. I was trying to find it in the chapter so you can keep up with me. Pass over. Are the azoles even in our chapter? Some help? Anybody gonna help me? Help me. Where is it? Protein synthesis, cell membrane function. Do we even have the azoles in here? Don't see nitrofurantoin. I don't see it. Are they even in our book at all?
They're not in the glossary or the index.
They're not in the glossary or the index. Ah, gosh. So ketoconazole. What about our in the mycology section? I've got some overview of fungals. Might be something we get on later. Let's see treatment. Where are we? Direct antimicrobial, molecular serological testing, treatment, all of our good pictures, lab safety, prevention, and we'll get into, wow, this might be the only place we get it then, right? That's pretty much it. So, what about miconazole? Do we have another name for that one? Who wants to be my checker here? Who wants to check for miconazole? Clotrimazole, miconazole. I know y'all had your phones out earlier. Who's going to check?
It's sold under the brand name Monostat.
Monostat. Wow. Has anybody ever heard of that? Good. All right. So again, monostat, think of that. Think of that's a real common name. A advertised name, a see it on the shelf name in the pharmacy. But we definitely have the azoles. All right. I'm thinking, good, he got off that. So the next one is the protein synthesis inhibitors. So when we think of proteins, I think we've got ourselves set up where we know how a protein is formed, hopefully. If we got that far, DNA, RNA to a protein, DNA, RNA, amino acids to a protein. Everybody got that pattern down? Everybody kind of knows that blueprint for protein. So when we talk about the inhibit protein synthesis, what we're talking about is inhibiting the process. So we have transcription inhibitors. And of course, transcription is basically going from a DNA to a messenger RNA. Okay, so in that path of DNA to RNA to amino acids to proteins, we have transcription inhibitors. The DNA strand is used as a template to produce a complementary strand of messenger RNA. The messenger RNA carries the information encoded in the DNA out of the nucleus. So that's that, I don't know if y'all remember nuclear pores. I remember talking about that. That's where that messenger RNA escapes the nucleus and goes out. So into the cytoplasm. And then there is translation of the messenger RNA by the ribosomes to give us protein synthesis with bringing in the different amino acid sequence. So a little review there for you. Actinomycin forms complex with the DNA, which prevents the progression of the messenger RNA formation along with the DNA template. So if I can't get to the messenger RNA, I'm not going to be able to continue. I'm not going to be able to replicate. I'm not going to be able to form new people, right? So the spectrum of activity for actinomycin is gram-positive and gram-negative, so it'd be a broad spectrum, and also a chemotherapy agent. So actinomycin, is there another name for actinomycin? I'm gonna rely on my front row Allison here with her.
Great. Dactynomycin is the generic name. Cosmegin, maybe? Not found it.
Nothing really outstanding there.
It just says that sometimes it's actinomycin D, which is dactynomycin,
Okay.
but nothing.
Where are we right now in the text? Inhibited protein synthesis, is that where we are? Including aminoglycosides. If we got there, we got to the aminoglycosides. Not yet, okay. Rifamycin inactivates RNA polymerase, preventing transcription. So if I can't transcribe, so I've gotten the messenger RNA, but the rifamycins will inactivate the polymerase from continuing. And rifamycin, we know we had it earlier. Remember that with mycobacteria. What's the M stand for again? Tuberculosis. What's the first one? Or it's the first part of tuberculosis? What's the M stand for? Mycoplasma or something else. Not mycoplasma, is it? The M in front of tuberculosis, what does it stand for?
Is it microbacterium?
Yes, okay, yeah, okay. Wanted to hear the confidence. We're gonna be interactive here for the next couple of days. If you hadn't figured that out yet, hopefully you have. Because we're kind of wrapping it up. So I'm kind of like, what? I'm trying to make sure I've got some info in you to basically have a conversation as a microbiologist at this point, hopefully. Okay. I know y'all don't like that, you hate that, but we're gonna do a little bit of it because that's the challenge. Communicate what you know when it comes time to talk about the antibiotics. Did we talk about rifamycin as a treatment for TB? There was a group of 3. Remember that 3? I know we've already had this test, so that's why I'm plugging for info. We had a group of 3 drugs. Remember that for TB treatment? There was a regime. There was a recommended, you need this one, and this one. Y'all remember that at all? Hallie, do you remember that? Since you had the name, do you remember the 3 drugs? 3 drugs. Zoom, do y'all know? Y'all are out there, got your access. We can't see you, so we know you're got your browsers open. What do you think? What are the 3 drugs for TB treatment?
Well, this one lists 4.
4, got 4. That's good. I'll take 4. Is this one of them? Rifamycin.
It's rifampin.
Rifampin. Oh, so it's name change. Okay, but it would probably be a rifamycin, even though it's called rifampin.
Yeah.
Okay, you got another one?
We have ethambutol.
What was that?
Ethambutol.
FN?
Also called myambutol.
Myambutol. Okay.
I don't know how to say it. Hybranzinamide. Something.
Okay.
And then it also lists ion acid something.
Okay.
These are your generic.
All right.
This is Mayo Clinic. This is what you list.
Okay. We'll keep working on those. All right. Here's rifamycin. Rifamycin. Pretty complex. A lot of carbons, sodium in there, salt. Don't see what? What do I not see?
The beta-lactam.
Or do I?
Did I miss it?
I don't know. Y'all remember the beta-lactam ring? What did it look like?
The square.
Or square? Oh. Those were our transcription inhibitors. Translation inhibitors, going to get a little, I think a more familiar group. But translation inhibitors, this is where the messenger RNA is there. Okay, it's going to be translated into, it's a sequence of amino acids using the transfer RNA, followed by the formation of peptide bonds. This occurs in the ribosome. And we know bacterial ribosomes are 30S, 50S, and that's just the size, weight of them. Is it spin units? It's the S. Subunits are combined to form a 70S. I know it doesn't make sense because 30 and 50 should add up to 80, but it does not. And then eukaryotic ribosomes, that would be us, right? Eukaryotic, we have a 40S and a 60S subunit combines to make the 80S. So if you see anything with 70S, you know it's bacterial. If you see anything with 80S, you know it's eukaryotic. So this is where we get back to our text, where we have aminoglycosides. Kanamycin, gentamicin, tobramycin, spectinomycin, and streptomycin. All those mycins, right? That's where we've been. We've been with the mycins ever since we were back here, right? We had a rifamycin, an actinomycin. So it's kind of easy to think about protein synthesis inhibitors having mycin on them. That's the way I like to do it. So back to our group here. Any of you heard any of these? Any of you been given any of these? Gentamicin is pretty familiar. Lauren says yes. Yay, thanks, Lauren. But there are side effects to the aminoglycosides, ototoxicity, okay? I know y'all took A&P, right? And I'm sure the 8th cranial nerve was part of your A&P, right? Remember that? Toxic to the 8th cranial nerve affecting hearing. So definitely an ototoxicity with these. So to be great for our patient, and also nephrotoxicity. And what's nephrotoxicity? Kidneys, right? So the reason I bring up gentamicin, and these, any of these, we need to monitor their level. So that's where we come in with the chemistry part of the lab. And Heather's not here, she's on Zoom. Hey Heather, you're on Zoom, right? Y'all talk about any of these peak and troughs yet in clinical chem? With gentamicin maybe?
Yeah, I believe so.
You believe so? Okay, good, you're
Yeah.
there. All right, so gentamicin, we have to monitor it because we don't want it to get to a certain level in the kidney or the 8th cranial nerve, right, to cause problems. So we'll hear what's known as a peak and trough. So it's a good time for us to do this. So Heather, explain to us what a peak and trough is.
Why do you always have to put me on the spot?
Always putting you on this because you
Oh.
let me know you've been in clinical chemistry already. I'll help you. I'll help you out. Okay, so gentamicin is one of the most common ones we do. You work with the pharmacist at this point. You work with the nurses at this point. And you work with your phlebotomist. If you're not the phlebotomist, this is where it comes up. So you get the order, it shows up, and it says, hey, we need a peak and trough on patient.
Oh, it's talking about times of draw. When
That's part of it. That's the phlebotomy part, time of draw.
Yeah.
Right? And they will tell you we need a peak and trough, okay, after. And that's the key, and that's where it's been confused. I mean, I worked confused for years on this, so that's why I'm slowing down and bringing this up, since we finally got one, gentamicin. The peak and trough from the pharmacist's point of view is after we've got so many doses in. Okay, so these are usually given in a 12-hour dose, every 12 hours, every, you know, it could be every 24 hours. You don't know. That's where you got to work with who? The nurse. The nurse is going to set up that order because the nurse is going to say, okay, we gave them the first dose today. We're going to give them another dose tomorrow. So we're going to give them the third dose on the third day. Or if it's every 12 hours, then it would work out where it's a certain, could be middle of the night, right? Could be, right? So this is when you go, this is when I'd always go talk kindly to the nurse who was on the night shift and wondering, since I had a peak and trough due at 3 a.m., there'd be any way possible you could draw that before you hung the next that dose, right? And we'll run it at 6 when I get there, right? So that was one point with phlebotomy. The other part is that we used to think that if it said peak and trough after the third dose, that meant that we would run a trough in front of the third dose, and that's incorrect. And that's the point I want to make. It's called peak and trough for a reason. We thought it was the other way around. We thought it should have been, why don't they call it trough and peak? We're always drawing the trough before the third dose and then drawing a peak after the third dose, right? Because we thought the peak and trough after the third dose. Y'all follow me? Or is this confusing to you? So really with the pharmacist's help, it was, hey, we want to get 3 full doses of gentamicin in. We're not worried about what it is until we get the third dose in. So the reason they would say peak and trough would be we want the peak after the third dose, which usually meant how long the infusion was. So you would look up peak and trough for gentamicin and it would say, okay, you need it immediately after a 1 hour dose, or 30 minutes after anything longer than that, or something like that. So you have to know there is a protocol for when these need to be drawn. So you'd always have to ask the nurse, please let me know when the bag is infused. When the infusion has finished, then I will know to come draw the blood and run the peak after the third dose. The trough then becomes before the fourth dose. Okay, so the peak and trough name is correct. It's after a certain dose. And what we're doing is we're monitoring the patient for any problems. Because guess what? If the patient already has renal insufficiency, that dose may get to the point of toxicity. They're not clearing it like you would. You clear a dose of gentamicin, like, gone, okay? An older patient or somebody that's having renal problems, it may take a while. They may not ever clear it. It may build up in their kidneys and cause nephrotoxicity that we're harming the patient now with the gentamicin dose. So the dose needs to be adjusted after that third dose if they're maintaining the peak too long. So the peak should be certain, they might say the peak needs to be 10 milligrams to 20 milligrams found in the serum at that point. It might be 30 after that next dose. That's way too high. And then the peak, who should be like at 5 to 6 milligrams before the next dose, okay? Some people treat it as, hey, we need to make sure it's at a certain level so the patient's getting enough antibiotic to make it worthwhile. But really the reason we do peak and trough is to make sure we're not harming the patient with the dose of an aminoglycoside, which if it builds up into a certain area can cause toxicity. So keep that in mind. Even if you show up, right, and you show up at a hospital and they say your job is to do phlebotomy also, and we need peaks and troughs, and if they hadn't made that point to you, review it and make sure that you're not asking yourself why it should be called trough and peak, that the nurses are asking you to come draw a trough before they give that next dose. The dose has already been made, okay? That third dose has already been made up and in the fridge in the pharmacy waiting to be given. So what the pharmacist wants to know is, do I need to adjust it after that dose? But we want to get those 3 doses in. So you'll see different varieties of different things, but it is our way of monitoring the patient. Streptomycin. Streptomycin, a gram-negative and gram-positive bacteria, a treatment for who? Bursa, right? We saw Bursa in micro, right? Vancomycin-resistant Staph aureus. We hope you don't see that for a while, but if we did see Bursa or Visa, vancomycin intermediate Staph aureus, then we would be treating it with streptomycin, an aminoglycoside translation inhibitor, right? Don't forget that. Translation inhibitor. We also have aminoglycosides that are especially useful for M. tuberculosis in combination with other drugs. Do we need to get that knocked out? We need the 3 for this. Does our book have the 3 aminoglycosides for M. tuberculosis? Was one of this on your list, Allison? I can't remember. Was one of these on your list? Don't think so. Gentamicin, tobramycin for Pseudomonas infection. There's gentamicin. Okay. So we have other translation. Is it translational again? Where are we? Translational translational inhibitors. The inhibitor of the 30S subunit which along with the 50S makes the 70S. I know I'm messing with your math again. But the 30S subunit is inhibited by tetracycline. It's broad spectrum, gram-negative, gram-positive bacteria. It has side effects, okay? I'm living proof of that. I know you're thinking that. What is the side effect, Mr. Rector? Okay, you might know tetracycline side effect, where it might build up.
Gastrointestinal.
I don't have gastrointestinal problems. Is that what the book says?
Cutaneous phototoxicity.
Uh-oh. What is that again? Cutaneous phototoxicity?
Yeah, it's at the very bottom of the
Resulting in disease including photoallergic immune reaction. I don't think I have photoallergic. I thought I had a different tetracycline reaction. Anybody else find anything else? Tetracycline side effect? Tetracyclines? Because what I need to tell you is my dad's a pharmacist. So we always grew up, if we had anything, we didn't go see the doctor. We just got an extra antibiotic brought home for us. One of those tetracyclines.
The
Anybody?
main thing is teeth. It pops up that,
Teeth, yes.
yeah, mineralization and calcification will bind the calcium ions in the teeth
Yes.
through the gums.
Through the gums, and what does that do to the teeth?
It will cause an initial fluorescent yellow discolorization and sensitivity.
And pitting. You have pitting in your teeth too.
That's not.
It's not on there. So yeah, I had this like, I used to have this great like white teeth smile, right? Yeah, so if you look at anybody in the age, probably in the 50s, age 50 or older, around that age group, that was one of the side effects, was graying of the teeth. And I have that, so it's not like I have a bright white smile like I used to, but I have kind of a discolorization in the teeth, right? All from tetracycline. So not everything is as good as it sounds. No. So they didn't know that at first. Now they do know that. So tetracyclines, gram-negative and gram-positive bacteria, again, good, broad spectrum. Mycoplasma, rickettsia, chlamydia, some yeast and some protozoan, but tetracycline, I don't think I ever had a mycoplasma infection. I know I didn't have rickettsial. I know I didn't have chlamydia, but for whatever reasons, you might know why you might have taken tetracycline. Does it say what use is for tetracycline? Maybe in adolescent males. Anybody? Anybody want to think about it? Think about why I might have been on tetracycline without being mycoplasma, rickettsia, and chlamydia infected. I didn't have Neisseria gonorrhea.
Acne.
There you go. Yes. Yes, it was. Okay, thank you. Is that Heather? Did you find that?
Yes.
Yes, that was it. Acne treatment, tetracycline. All right. Nitrofurans. Nitrofurans, urinary tract infection only. One of the number ones that's given for urinary tract infections. Trying to find 169 nitrofurantoin. There it is. Consists of a nitro group, heterocyclic nitrofurantoin. Does anybody know the brand name of that? Maybe you've heard it. Anybody heard of nitrofurantoin? Does Anybody ever had a urinary tract infection?
It's also called serotonin macrobid.
Macrobid.
Or something.
Yeah, macrobid. So yeah, macrobid, just got refill of that for somebody in my house the other day. It was a macrobid. Tetracycline. We also have inhibitors of the 50S subunits. Again, 50 and 30 add up to 70. So we're still talking about bacteria. And we have chloramphenicol, which is a bacteriostatic, which means what? Remember we had that Tuesday. What was a bacteriostatic?
Stops bacterial growth.
Prevents replication, right? Keeps it from growing, all right? So the spectrum of activity for chloramphenicol, infections due to anaerobic bacteria, anaerobes. Should I ask, do we know an anaerobe? Somebody give me an anaerobe that we talked about the other day. An anaerobic bacteria. It's not Haemophilus influenza, but give me an anaerobe.
Clostridium.
Clostridium. Okay, thank you. Infections due to anaerobic bacteria or Haemophilus influenza. Haemophilus influenza, what do we know about Haemophilus influenza? Where did we use it the most? What lab did we have so much fun in?
X and V factor.
X and V, yes. Y'all remember that? Remember that? So chloramphenicol, do we have a name for chloramphenicol? Is it just chloram?
Chloromycetin, and then it lists a whole bunch of others, but nothing.
Anything familiar? Anything unique? Any? Chloramphenicol is pretty common, a name, I think. Side effects for my whole group of hematologists in here today, aplastic anemia. Here we go, aplastic anemia. Somebody want to take that one on? I got the anemia part, all right? But maybe not exactly the way you think of it here. Aplastic anemia, what does that refer to?
So it's a condition that occurs when your body stops producing enough new blood cells.
Yes, that is correct. Nobody heard that, right? Because I was looked up. I was expecting you guys as hematologists to throw that answer at me. Y'all should have hit me in the head with that one. Right? Aplastic anemia, that wasn't covered in the first little bit. Pete? Don't remember. Aplastic anemia is what most of you are probably thinking was what? It must be just red cell problems, right? But we heard from front row that it was all cells. All blood cells are low. Okay, so aplastic anemia. The good thing about this one is it is absorbed through the blood-brain barrier for central nervous system infections. So this would be against who? Who in that group, no, you're not thinking C. diff, who in this group would, why is it up here, right? What does Haemophilus influenza cause? Why did we even talk about it? See, y'all avoided all this conversation when we were rolling through all the organisms because we left out all the treatments. Now we're bringing the treatments back in, but we got to recall back why we were talking about Haemophilus influenza. Why were we talking about it? Why was it so important? H influenza.
Causes meningitis.
So that would be a good reason I'd want to jump the blood-brain barrier with it. Because if Haemophilus influenza has a guy that calls meningitis, I need something that can get to it. Not all of them can get to it. Chloramphenicol can. Okay? Makes sense now? Is it connecting? Are you connecting dots, hopefully, back to where we went for the first? Are we in the 9th week or still the 8th week? Which one are we in? We're in the 11th week? I don't think we're that far? Doesn't seem like 11. All right. Macrolids. Macrolids, this is not macrobid. It's not a nitrofurantoin. This is macrolid. Azithromycin, the most widely used agent in the macrolid group. Spectrum of activity, gram-positive organisms, Mycoplasma, Legionella, and Campylobacter. So macrolids, azithromycin. Has anybody ever taken azithromycin? And how was it prescribed? What was the name it was prescribed in? Because it's actually being used for COVID.
Z-Pack.
Z-Pack, is that what it is? Yep. Anybody heard of a Z-Pack? Usually a 5-day Z-Pack, five pills to take in the next 5 days, azithromycin. Most widely used agent in the macrolid group. Okay, gram-positive organisms, Mycoplasma, Legionella, Campylobacter. I don't know exactly why it's being considered as a treatment, but it is, according to my sister, who's also a pharmacist. Let me know that she has a COVID pack. She has something she fixes up for COVID patients. Wanted to know if I wanted it when I tested positive, and I said no, I'm good. But she has this, she's created this recommended, this is what everybody needs to have at their house when they have COVID. And one of that was having a Z-Pack in there. Clindamycin, again, mycins, we need to associate with who? Protein synthesis inhibitors, thank you. Okay, clindamycin, gram-positive cocci, and anaerobes, especially Bacteroides fragilis. Give me another gram-positive cocci. Strep's one. Staph one. Yep. Several. Clindamycin. Do we have another name for clindamycin? I think I made a list. I forgot to, I think I have a list of all my common names versus my drug names. Probably come next week. Cleocin? Yes. Sounds right. Chloramphenicol, azithromycin. Okay, so that was our protein synthesis, right? Inhibitors. And then we move on to our agents that interfere with DNA function. Synthesis. Now we're moving into our inhibitors of DNA and RNA. Yes. All right. Quinolones, fluoroquinolones, and nalidixic acid. Mode of action inhibits DNA replication. So we're not even able to divide into the DNA to get the sister chain of DNA. So it inhibits DNA gyrase. or topoisomerase 2 enzyme. And the ones we have here are the quinolones. Sinoxin and fluoroquinolones, ciprofloxacin. Anybody heard of that one? Otherwise known as who? Anybody familiar with the name? Cipro? Cipro, kind of shorten it up, ciprofloxacin. Treats a number of infections, including bone infection, joint infections, endocarditis, gastroenteritis, malignant otitis externa, respiratory tract infections, cellulitis, urinary tract infections, prostatitis, prostate irritation, I guess, anthrax, cankeroids, and among others. So very, very useful, very, very widely diagnosed. I mean, used or prescribed, I guess, prescribed for Cipro. Nalidixic acid, the first quinolone used clinically, used in urinary tract infections only. It can also be used against enteric gram-negative rods, but it's not effective against Pseudomonas aeruginosa or gram-positive cocci. So definitely our enteric rods, we use nalidixic acid, the first quinolone. Is there another name for nalidixic acid? That doesn't sound.
Neggram is the brand name.
What was it?
Neggram, like negative gram.
Negative gram? Okay, I think that's too simple. There's got to be a better name than that. Maybe there's not.
That's all I'm finding.
That's all you
It's
find?
oral medication.
What about levofloxacin? Look that one up for me. Levo, L-E-V-O, floxacin. Levofloxacin. We got ciprofloxacin. What about levofloxacin? I think I've heard of levo too.
It's
but
under Levaquin.
Levaquin. Oh my goodness. Anybody heard of that one? Y'all must not get sick very often. Anybody get sick? Yeah? No?
Lauren just put that in the group chat.
What's that?
Lauren put that in the, I don't know if you can see the chat or not.
Oh, I will. Let's go. Let me get
I've
back.
been blowing this chat up.
I know.
I can't see the chat. Hold on. Hold on. I think I have to stop the share to see the chat. That's why I can't see the chat. Here's Lauren. Lauren, you just have to break in and say stuff.
Well, I don't like interrupting, so I'm just like talking to myself basically in here.
Okay, so I see vancomycin is also a common IV. Yes, I think it's given IV. Very good. Entamibutol, iazine, and oh, you gave me your mycobacterium treater. So you could have
Yeah, like
interrupted.
everything you said, I was like,
Trust me, nobody in here is talking. So go ahead and just interrupt because they're just looking back at me right now. So tetracycline, nausea, vomiting, appetite, mouth sores, headaches. Okay, we covered that. Stops producing new blood cells, aplastic anemia, influenza used to treat chest infections, Cipro. All right, Levaquin turns pee red. Is that real? Or those are azo?
That's Azos.
Azo, yeah, that's it's not quite an antibiotic.
It's
right?
just for like the relief of a UTI. I
Yeah,
know that.
that's the comes when you do have a urinary tract infection, they give you azo tabs, which are analgesic painkillers.
Yeah, the first time I did a urinalysis on one, I was like, oh my gosh, this person's like dying because it was red and I thought it was all blood, but it really wasn't.
Very good point, because it really makes it orangey more so than reddish. So, but you may be right on the azos turning red. I think you're right. Okay. The antibiotic turns the urine red. I'm thinking of the azo analgesic that turns the urine orange. Y'all seen
Yeah,
that?
it's like an orangey red.
Something like the over the counter.
It's over the counter, right?
Yeah.
And it's for pain, but it ruins our urinalysis. We cannot do a urinalysis on an azo urine. Cannot.
Yeah, the strip is completely like out of whack.
And you have to just note that either you note no results or you have to note results may be altered due to medication. You can do that. You can still spin it down and look. You can still do a microscopic. But definitely something, yeah, that needs to be brought up too, because we cannot do a urinalysis. That should have been in Heather, that should have been in Clem Kim. No, body fluids. Anybody taking body fluids? Body
Yeah.
fluids, urinalysis?
Yes.
Take that one too? Heather?
Yeah.
Yeah,
have.
y'all talk about that? Hopefully.
I've taken it, but I don't remember talking about azos.
Yeah, me neither. I mean,
Because I've worked in the clinic and we would still do urinalysis on people with azos and I would just note it in their chart.
Yeah, it's a good time to bring it up because we're talking about urinary tract infection. So we can put that in micro. I'm good with that. Yeah, but you don't report it because it's going to give very abnormal results. That's the key to these, because your urinalysis, if you haven't done the little dipstick yet, the little 10 square dip, it just reads color. It's reading color change. So orange just masks all of it. And it makes it wild. It gives you bilirubin real high. It gives you, everything is high. Just put it that way. And it freaks people out. If they see that, they think, oh my gosh, you know. And it might not, you know, it's not reportable. You shouldn't be reporting it. So anyway, I've got some of that at home. I don't know if anybody wants to take it, see the urine. Anyway, but yeah, no fun. All right, so let's go back. Let's share our screen again. Yeah, I can't see chat, so you're gonna have to talk. I can't pick it up without you talking. Okay. Love you too. All right. Cipro, Levaquin. What about novobiocin? Inhibits that DNA replication. The DNA gyrase can't happen because of novobiocin. Spectrum of activity, gram-positive bacteria, which would be the gram-positive bacteria that's penicillin resistant staph. Okay. So novobiocin. Anybody got another name for novo?
Albomycin.
What was it?
Albomycin. Or cathomycin. And albo.
Catho, althos, not anything really familiar, I don't think. Griseofluven. Mode of action interferes with mitosis. Binds to the tubulin, interfering with microtubulin form function. This is for our dermatophytic infections. Requires a prolonged treatment of 6 months to a year. Grisofluven. How did we get to this one? All of a sudden, I just jumped to grisofluven. Is it part of our DNA inhibitors?
Is it because it deals with the mitosis?
Mitosis, sure. What is a dermatophytic infection? I don't even know if this is in the chapter. Is this in the chapter? Griseofluven. Probably just a little hint.
It's a fungal infection of the skin, hair, and nails.
So we're really having trouble bringing in what? The fungus treaters here. Yeah, dermatophytic infection is a fungal infector treatment. Prolonged treatment, going to require us a long time to get rid of it. Is there another name for griseofluven? No. Nothing common, more common than griseofluvin.
It just says the brand is Gris-PEG.
PE what?
G.
G, PEG, Gris-PEG. Okay. All right, we're getting closer. We're kind of moving into our metabolic process inhibitors, antagonist, competitive antagonist. And we see one here is para-aminobenzoic acid, PABA. These are analogs of PABA. PABA is a precursor of folic acid. These antibiotics compete with PABA for the enzyme required for the synthesis of folic acid. Do I dare ask what the patient might be low in if I'll let y'all. Have you heard of folic acid? Do we run folic acids on people? For what?
It has to do with an anemia. I don't remember.
I didn't want to go too far into hematology, but you were on the right track. Yes, folic acid. Yes, y'all heard of that? You've heard of folic acid? Yeah. Okay. Where else would we want to make sure somebody takes folic acid? Heather might be the only one to answer this one. Neural tube defect is folic acid deficient. That's what happens. Okay, so you have to take prenatal vitamin. Folic acid. Okay. Sulfonamides. Sulfamexo. Oxazole, sulfasalazine, gram-positive and gram-negative bacteria. It seems to be pretty much, for most, we got both covered for the most part. Enterobacteriaceae, our enterics, our Haemophilus influenza, Staph aureus, our strep pyogenes, and our strep pneumo. Remember, I was hoping you'd, make sure you knew those S's. Sulfonamides, PABA, competers. We have para-aminosalicylic acid, PAS, Mycobacterium tuberculosis only. We have our sulfones, our dapsone for leprosy, Mycobacterium leprae. Our trimethoprim used in a combination with sulmexazole to treat urinary tract infections, otherwise known as Septra. So, anybody remember the little antimicrobial panel we gave the other day in lab? And you were going through the list and you maybe saw some that were like one and a slash and something else in combination. Some of our antibiotics are given in combination of two different ones. So we had that. So you may connect trimethoprim with sulfamexazole to form Spectra. So is anybody, what's Spectra? Is that even used as a name anymore?
It's trimethoprim and sulfamethoxazole. It's a
Okay,
synthetic antibacterial.
we're able to find it. Thank you, Laura. Dapsone for leprosy, para-aminosalicylic acid. What is salicylic acid? Heather?
Another chemistry question.
Yes.
See, I think I would know these questions, like I know them until you ask them type situation, you know.
Okay. Aminosalicylic acid. Am I able to get, hey, I'm maybe get, Hey, I'm able to get to chat. Here we go. I can't get to it though. Sorry, I can't see the chat. Somebody put something in the chat. I can't. It popped up. Doesn't look like I can get there unless I quit
I was
sharing.
trying to help Heather out in the chat.
Well, you can. Oh, you sent a private message.
No, I sent it to everyone, but I didn't think you were going to look at it. So
What
I
did you
sent
send?
it.
I'll call on you, Lauren. Lauren, what'd you send?
The
I
acne
just,
one?
yeah, it says used for acne on mine.
What's
Oh,
that?
okay.
It's like a skin treatment.
A skin treatment?
Yeah, you use salicylic acid to get rid of like pimples and stuff.
Oh, you do?
It like kills a layer of skin.
Oh, okay.
I think that's supposed to be popular now, but then other people say not to use it. So
Okay. All right. Good job. So this says for FYI only. You know me, it's here. So you never know, it might come back. Dapsone is used prophylactically to prevent pneumocystis gyrovecii, right? Gyrovecii, a pneumonia and toxoplasmosis in patient unable to tolerate trimethoprim with sulfamethoxazole. Dapsone is also used to treat brown recluse spider bites because it's an anti-inflammatory agent. So that's, to me, that's FYI, but you know, people get bit by brown recluses all the time. So definitely good to know. Okay. Isoniazid, NINH. Is this one of ours, Allison, that you came up with earlier?
Yes, sir.
Yes, you can see that the reason we are harped on that is because we're kind of covering them as we go one by one. So the mode of action inhibits the synthesis of mycolic acid required for Mycobacterium cell wall. Inhibits the fatty acid synthetase, an enzyme involved in production of the mycolic acid. And you remember with Mycobacterium tuberculosis, we use what to see it? Acid fast stains. Hoping y'all can remember that. So only used to treat tuberculosis, TB. Always involves multi-drug treatment to prevent the emergence of a drug-resistant strain. Isoniazid. Okay. So I think I'm going to introduce, what slide are we on right now?
63.
63, and how many do we have?
74 or 73. I'm always off.
Okay, that's good. We're right at, I think we're good. We just hit the 12:04 time period, so we're good. Antibiotic resistance. So that's our group. That's our drugs. We made our way through the antimicrobials. So now we need to focus on the next step, which is what makes them anti-resistant. What makes them resistant to the antibiotics? What does the actual organism do? So this is where we're concerned with the most, because this is where we have drug-resistant bacteria that actually lead to death. 23,000 deaths, over 2 million illnesses a year just in the United States, according to CDC. The pathogens have been labeled urgent or serious threats. These are our big ones by the CDC. They say Staph aureus, methicillin resistant, or as you learned Tuesday, ORSA, right? ORSA, bloodstream infections. Clostridium difficile is a big one. We're working our way into doing some work downstairs with those two organisms. I think I mentioned that already, that we got MRSA and C. diff, which is now Clostridioides difficile. Remember that from our lecture way back when we did the name change? Hospital-acquired carbapenem resistant Enterobacteriaceae, CRE infections, and hospital-acquired multi-drug resistant Pseudomonas infections. And we're already doing work downstairs with Pseudomonas. And get some this week between floors 1 and 4. So if you didn't know, just to put a little plug in, if that interests you, then we do have some ways of doing that, which is you can enter in CLS 410V if you just so want to do some extra work while you're on campus, okay? We always find, there's always work going on. So basically when I have a student, I have 2 this semester, and what I let them do is they do the hands-on research part of doing the experiments that we're running through with Pseudomonas right now. We're using Pseudomonas aeruginosa for wound infection. And we're doing a light therapy with it right now. It's blue light therapy, working with PT. So if you had an interest in maybe ended up in PT in the DPT program, it'd be a good way to meet one of the professors from PT. Just throwing that out there, because some of you may or may not know that's available, and your advisor may or may wait till you say, hey, I need 1 more hour for something, and they'll tell you to go get into some disaster preparedness class, and you could actually enter into a 410V and get that. It's variable to how long you're here each week. It'd be 1 hour, 2 hours, or 3 hours. And that's not 1 hour per week. That's, 1 hour a day. That's 4 hours a week for the 1 hour, because it's a lab course. I didn't know if you knew this, but lab is 4 hours for 1 hour credit. If you need 2 hours of credit, you have to do 8 hours a week. And if you do you need 3 hours of credit, you would have to do 12 hours a week. Okay, so it can add up pretty quick. So right now it's usually in the mornings, on Tuesdays and Thursdays for sure. So keep that in mind in case you want to come back, because we should be working with these 2 groups next semester, hopefully with the staph aureus, MRSA, and C. diff, and Pseudomonas too. We'll keep working with Pseudomonas. So how does a bacteria become resistant? So we're just going to kind of introduce this. We'll pick it up. We're at 12:10. We got 5 minutes. We may fit. We're going to continue talking, but what the bacteria does, it can do several things. It can modify the receptor site or the binding site of the antibiotic. Okay, so the antibiotic wants to get a hold of Pseudomonas. If I want to start being resistant because I knew that was what the antibiotic wanted to do, I modify my receptor site. Make it harder for that antibiotic to bind to me than show me to other things like phagocytic cells. Inactivation of the antimicrobial agent. I can just shoot out beta-lactamase, right? I can produce that. Learn how to produce that. Know that that keeps me from being destroyed by penicillin. Okay, so we have beta-lactamase going after that ring or square that we talked about. We have decreased membrane permeability in entry through altered porin channels, active transport system, or modification of the antibiotic. So I can make it harder for the antibiotic to enter me. Synthesis of an alternative enzyme. I can start producing my own enzyme. Pathway, or that bypasses the vulnerable pathway, replacement of the enzyme, or any of the combinations of the following of those. So I just want to harp on this. The last new class of antibiotic versus a gram-negative rod was created. Now we look at it, what was 4 decades ago. Okay, so I'm taking that this was 1970. Now it would be 5 decades, right? So you see when all the sulfonamides were 1930, the penicillin was 1940, with aminoglycosides, chloramphenicol, tetracycline, macrolides, and glycopeptides, 50s. Streptogramins, the quinolones, the lincosamides, the trimethoprim, oxaloacetam, in the 2000s. So we'll finish with this of methicillin resistant Staph aureus or ORSA, because now you know it's oxacillin, because oxacillin has replaced methicillin as the name of the actual antibiotic. It's moved from methicillin to oxacillin. It used to be hospital alone. Now it's community. So the hospital strains are still more multi-resistant, where we still might have something that's useful. And this doesn't mean, oh my gosh, we talk about, going straight to vancomycin. The reason we give you the pattern of all the sensitivities is there might be something simpler that works against your MRSA. If it's community acquired, sure. So what makes methicillin resistant is something called the MEK-A gene. They carry it. Staph aureus carries a MEK-A gene that encodes an altered penicillin binding protein, PBP2A, whose affinity for the beta-lactam antibiotic is greatly reduced. So you remember, the the penicillin binds the proteins at the therapeutic level, methicillin that would inhibit the transpeptidational cross-linking activity of the other PPPs. 2A remains active, thus keeping what? Keeping the cell wall strong, okay? So it limits the degree of cross-linking is enough to ensure survival of the cell. So we call these, we also have some that are called extended spectrum beta lactamases, ESBL, and I have these when I ID antibiotics. These comes across as on my report form that this is an ESBL. They have the ability to destroy carboxypenicillins, tigercillin, and carbacillin, piperacillin, meslocicillin, and azotrianam, as well as cephalosporins, other cephatoxin. Help me out with that. Cefoxitin, thank you. In addition, they tend to be resistant to fluoroquinolones and aminoglycosides. They're usually susceptible to carbapenems, the imipenems, the meropenems, and the doropenem, and the ertapenems. The cefamycins, cefoxitin, right, Alex? And the beta-lactamase inhibitors, clavulanic acid, tazobactam, and sublactam. That is a lot in one slide. It is. It's too much in one slide. So what we're going to do is we're going to start back at ESBLs when we come back. We got E. coli and Kleb pneumo are well known for their ability to produce ESBLs, and that's the one I see. You see E. coli and Kleb a lot. They can also be found on other enterobacteries, but these are the ones we used to. And as it says, any organism shown to be an ESBL producer requires all penicillins, cephalosporins, and azotrianams to be reported as resistant, regardless of what it says. So you get help from the computer these days, but we have to change that. We cannot say that you're sensitive to penicillin if that organism is producing extended spectrum beta lactamases. All right, we're going to come back to those last two, finish this up, stop the share, end the meeting.